be Dr. Yehia Omar. He's a radiology and nuclear medicine professor, and that's about the value of nuclear medicine in cancer prostate.
Thank you, Professor Dr. Rafi, for the introduction. I want to thank Professor Dr. Lubna and Professor Dr. Hisham for their invitation. It's always a pleasure to be in the Ain Shams Oncology Conference. So I'm going to present today the value of nuclear medicine in cancer prostate. It will mainly be into two parts. The first part is to know the value of nuclear medicine using PSMA PET-CT in the diagnosis of cancer prostate, and the second section will be about the value of nuclear medicine in therapy using lutetium PSMA. So first I want to start by a new concept that we have in nuclear medicine, which is called theranostics. And theranostics is the combination of two words, the word therapeutics and the word diagnostics. And the main idea behind this concept in the nuclear medicine is that specific tumor cells have specific receptors on their surface. And we are able to target this specific receptor twice. The first time is to have an accurate diagnostic test, and the second time to target the same receptor, but this time for therapy and not for diagnosis. So today we are discussing cancer prostate. So today we know that cancer prostate cells have PSMA receptors on their surface, and this is a specific receptor unique to cancer prostate cells. So this is our magical receptor that we are going to target twice, as I said. The first time by injecting a diagnostic isotope, which can be gallium or fluorine PSMA, and now we can have a whole body diagnostic scan. Then we shift and use the other isotope to target the same receptor on cancer prostate cells, but this time the lutetium is a beta emitter which reaches the cancer prostate cells and emits radiation inside cancer cells, causing cell destruction. And this concept is growing rapidly in the nuclear medicine. Now we have cancer prostate theranostics, and we have neuroendocrine theranostics, and in the future they are going to try to replicate the same idea in other diseases. So this is the future. Now let's start by the value of the diagnosis using PSMA PET-CT. I'm going to start by the indications in the NCCN guidelines. I'm going to quote the next paragraph, which is saying PSMA PET-CT can be considered as an alternative to standard imaging of bone and soft tissue for initial staging, for biochemical recurrence, and as a workup for progression. Now I want to highlight this very interesting trial, which is called PRO-PSMA, and this was published in The Lancet. And in this trial, they wanted to see the difference in staging high-risk patients by using the old conventional method, which is CT plus bone scan, which will be in one arm, versus the new scan, which is the PSMA PET-CT. So they enrolled 300 high-risk patients, CT plus bone scan in one arm versus PSMA PET-CT in the other arm, and then they did crossover to see the difference in results. And they found that PSMA PET-CT had 27% greater accuracy than conventional imaging. So the accuracy was 92% in the PSMA PET arm compared to 65 in CT plus bone scan. And also the PSMA PET had fewer uncertain results, and that led to greater treatment impact. The treatment impact was 28% in PSMA versus 15. And the main treatment changes were shifting patients from curative to palliative intent and changing the surgical technique and changing the radiotherapy technique. I think one of the very important fields in the future, like Professor Dr. Hassan said, will be what will boom in the future is the metastasis-directed therapy using PSMA PET. So I want to highlight this very nice trial, which is called the STOMP trial, published in the Journal of Clinical Oncology, and it was titled they divided the patients into two groups. First group, they received metastasis-directed therapy based on the results of the PET scan, and the other group had only surveillance. The idea is that if we can have a sensitive and a specific tool like PSMA PET, we can design the therapy according to an accurate results. المفروض اللي كان هيطلع هنا ان according to this trial, the 5-year ADT survival was elongated in the arm of the metastasis-directed therapy. So when we have an accurate exam, we can have an accurate management, and the accurate management will lead to better patient outcome. هنا كان في 5-year ADT free survival. فالبيشنتس في 35% منهم ما أخدوش ADT لمدة 5 سنين بناء على this therapy. Another therapy showing the value of having treatment based on radiotherapy, this publication titled Efficacy of PSMA PET Guided Radiotherapy for Oligometastatic Castrate-Resistant Patients. They had 42 patients, oligometastatic, received radiation based on the PSMA PET. We found out that most of the patients had very good PSA response. The median PFS was 12 months, and according to that, you are able to postpone initiating the second-line systemic treatment for 15 months. Again, very important outcome if we can postpone giving another line systemic treatment. Now let's move to the interesting part, the therapy part, the value of lutetium PSMA. I'm going to start by this article. This article was published in the biggest journal of nuclear medicine in the world, the Journal of Nuclear Medicine, and the title of this article was Lutetium PSMA, one of the greatest success stories in the history of nuclear medicine. Very striking article and very striking heading, and that was in August 2021. And this is what I will try to show you now. So this is a very busy slide showing multiple clinical trials using lutetium with many combination treatments. Most of the studies, the results are not yet. However, the results appeared for the VISION trial, and that is metastatic third-line level. Then therapy, again, metastatic castrate-resistant third line. And recently, 10 days ago in the ESMO, two presentations, two trials were presented in the last ESMO, PSMA4, and we're going to discuss it, and INZA-P also presented at last ESMO. So what we notice is that lutetium PSMA is being shifted from the end stage. Now we are pushing it to earlier in the disease stages of the patient. From the third line, now we are pushing to the second line, and now we are pushing to the first line. So this is the future of lutetium PSMA. Now let's start by the biggest trial performed on PSMA, which was the VISION trial. I want to highlight the inclusion criteria. The first one is something called PSMA positive disease, and we are going to discuss that in the following slides. The second patient population was they had previous taxane and previous new generation anti-androgen, and they were randomized versus standard of care. And in this arm, there was no really active drug, no life-prolonging drug, only standard of care. However, the trial was positive. there was improvement in the PFS with hazard ratio 0.4, improvement in the overall survival with hazard ratio 0.62, and a very interesting comment was said by Oliver Salter, who was the principal investigator of the VISION trial. After he finished the trial, he said that what he noticed is that patients who received lutetium PSMA were basically living longer and living better. So this is a very important conclusion that we need to reach, that patients who receive lutetium PSMA living longer and living better. And according to the positive results of this trial, lutetium PSMA was FDA approved in March 2022. Now, another very important trial, and that was published in The Lancet. This time, they compared lutetium PSMA with an active drug, cabazitaxel. And these in patients that have PSMA positive disease. Again, we're going to describe what does it mean later on. And the patients had previous docetaxel. So now the randomization, we have lutetium in one arm and an active life-prolonging drug in the second arm, which is cabazitaxel. So lutetium PSMA had better response rate. The PSA 50 was 66% in the arm of lutetium compared to 37% in the arm of cabazitaxel, and lower side effects, which is a very important point. The lutetium PSMA had lower grade 3 and 4 toxicity, 35% compared to 54% in the cabazitaxel arm. And the lutetium PSMA side effects were mainly thrombocytopenia, dry mouth, dry eyes, and cabazitaxel, of course, as you all know, more neutropenia, diarrhea, and neuropathy. This recent trial, again, as I said, was presented in ESMO 10 days ago. And now what's interesting is that lutetium PSMA is being shifted earlier in the taxane-naive patients. That's what is interesting and what's new now. So in this trial, again, the patients need to have PSMA positive disease and they have progressed on a previous new generation anti-androgen. Now they are divided into two arms, lutetium PSMA arm compared to changing to the other androgen receptor pathway inhibitor. We know that changing to another ARPI is not that effective, but however, this is how the trial was designed. And again, the study was positive. The efficacy results were impressive. The PFS was doubled, 12 months in the arm of lutetium compared to almost 6 months in the arm of ARPI change. The PSA decline was almost 60% in the lutetium compared to 20%, and better objective response rates. Even the quality of life was better in the lutetium arm. We had better pain control and better symptomatic skeletal event, so better efficacy, better quality of life, and what was striking to me, even better side effects. So lutetium PSMA had better side effects compared to changing to the second ARPI. So the grade 3 side effects were 34 compared to 43 in the ARPI change. Serious adverse events 20 compared to 28, and the adverse events leading to discontinuation 6 compared to 5. So what we can see now is that lutetium PSMA is almost similar to the ARPI change, but it has better efficacy, better quality of life, and lower toxicity. Very, very important points. Now, the main point that I said several times, what is the meaning of PSMA positive disease? Because this is how we select our patients. So when we have a patient with high SUV max, like this patient has a lesion in the left sacrum, SUV 95. What does this mean? It means high amount of receptors. What does it mean? It means that the tumor will absorb lutetium a lot inside the cells, and that will lead to cell death. So good response when we have high SUV. Now let's see the opposite. If you have low SUV, like 9 SUV, what does it mean? It means that the cancer cells have low amount of receptors, so will not absorb the treatment. So what will happen? No or bad response. So this is a very important point, how to select our patients. And that was proven in the Vision trial. In this PFS, the patients were divided into 4 groups according to their SUV level. So the blue line has the best PFS, and these patients has the highest SUV. The green line, lower PFS, lower SUV, then the orange, then the red. فاضل لي 2 slides or 3 slides also. It is proven that the higher the SUV, the better the response. I will show 2 cases that we performed at our department. So this is a 77-year-old patient, post-docetaxel, abiraterone, and cabazitaxel. And this is the initial results. This patient had metastatic bony lesions and lymph nodes, and the lymph nodes were compressing the IVC. As you can see, the IVC is the tube marked in white. The lymph nodes were compressing the IVC, causing lower limb edema. This patient actually received 2 doses of lutetium PSMA, and in the follow-up, we can see marked resolution of most of the lesions. The lymph nodes showed shrinkage in size. The IVC was back open. The patient was doing better. Improvement in quality of life. The lower limb edema resolved, and the PSA decreased almost 98% in this patient. Another patient, 68 years old, post-docetaxel, enzalutamide, and cabazitaxel, again diffuse metastatic bony lesions in the spine and pelvic lymph nodes. And this patient is called actually a super responder. Super responders are patients who respond very quickly with lutetium. So this patient had only a single dose, and this is the follow-up scan showing again resolution of most of the lesions. The pelvic lymph nodes disappeared, and the PSA dropped almost 98%. This is the final slide. Again, another patient, post-docetaxel and abiraterone, diffuse bony and nodal metastasis. He received 2 doses over the course of 7 months, and this is the follow-up scan showing resolution again of most of the lesion. The patient was doing very good. PSA dropping again almost 94%. So to conclude, gallium PSMA has better accuracy than conventional imaging. It leads to management changes with improved patient outcome in certain scenarios. And lutetium PSMA is FDA approved, shows high efficacy, and more importantly, with low toxicity profile, and finally leads to marked improvement in the quality of life. Thank you very much.
Thank you, Dr. Yehia.